We've got increasing use of our social media, of our device time, of our screens as we are all sitting here watching and listening to us, right? We have studies that show that our blink rate, normal blink rate is about 20 times per minute. When we're reading or doing something, when we're paying attention, we're down to about 10 times per minute. And then when we're on a device, specifically, we're down to about 7 times per minute. And that leads to this lack of re-stabilization and homeostasis of that tear film and redistribution of the fluid there. So then we get this time where we've got exposure. That's going to lead to dryness. That leads to what we were just talking about, which is damage to those skin cells on the front surface, among other things.
Now, this episode of the Dr. Alice podcast is made possible with support from TheraTears. TheraTears makes not only high-quality artificial tears, but eyelid cleansers and omega-3 supplements trusted by eye doctors everywhere. So huge shout out and thank you to TheraTears, and we'll have more on them later. Hey, eyes and shine, and welcome to the Dr. Eye Health podcast. I'm your host, Dr. Joseph Allen, and today I am joined by Dr. Cecelia Koetting, an assistant professor at the University of Colorado School of Medicine in the Department of Ophthalmology in Denver. Dr. Koetting specializes in anterior segment and ocular surface disease, neurooptometry, and perioperative care, and is actively involved in clinical research. And today we're digging into one of the most common and one of the most misunderstood conditions in all of eye care, and that is dry eye disease, otherwise known as dry eye syndrome. And today we talk about what actually causes dry eye, why we are starting to see younger individuals develop these symptoms, and some of the complexities that eye doctors and dry eye specialists have to look for during dry eye evaluations. Dr. Koetting also shares some practical, real-world strategies that can often help get symptoms under control and help protect the ocular surface. Otherwise, let's dive into the episode. So let's talk about dry eye disease, because this is something I know you and I both see quite a bit in the clinic, but there's definitely a disconnect because I know some people will think, just my eyes are dry once in a while. They feel a little dry, but they don't understand like the gravity of really what's going on, certainly from the doctor's perspective, like what we see.
Yeah.
So can you kind of break down or share with us like how you think of and understand dry eye and dry eye disease?
Yeah, absolutely. And that's a great question. And that's an ever evolving answer, right? The more that we know, the more it changes, and the more I learn and how I'm dealing with patients, it changes. But you're right. Our understanding as patients, because you and I are still patients as well, even though we're also doctors, as a patient, we think of dry eye, or our patients think of dry eye as just something that's there, right? It's just dry eye. And it's kind of funny because many times my patients, when they see me as a dry eye specialist, will go, I didn't even know that there was a specialty, right? And I didn't realize it was this big an issue. And so I like to help patients understand that it really is everyone that has it. Right? At some point in your life, you're going to have dry eye, and to what level is going to be different. And that may change throughout your journey. And we'll talk about, the underlying causes in a little bit, I'm sure, but that's going to be part of this, right? What's changed in your life that's changing your symptoms that are here. And, when we talk about dry eye, we try to not just say it's just dry eye, right? We say dry eye disease. But I argue, I don't know that disease is the right word either. I think syndrome is actually probably the more appropriate word when we start thinking about, definition of disease versus syndrome. A disease is more specific, a medical condition with a clearly defined cause, pathological process, usually a predictable course and outcome. And I think you and I can appreciate that this is not that. It is something that ebbs and flows, and there are so many different underlying causes and so many different potential treatments that the disease is probably not appropriate. But I think the word disease at least holds more gravity to our patients to say, hey, this is a bigger problem. This isn't just dry eye. So I think it's a good start. I think more appropriately, yes, it should be dry eye syndrome, but I'm at least happy to call it a disease so that people understand it's an issue.
And then I know an older term that still is used pretty frequently, but I feel like there's been confusion about when we should be calling it keratoconjunctivitis sicca,
Yeah.
right? I don't mean to throw out that term for anyone who's like, I've never heard that term before. But when I went to school like over a decade ago, that was known as like the medical term for dry eye.
Yeah.
And there was even some medications at that time where you couldn't even prescribe it unless you specifically put that verbiage in the chart. So I'm curious, do you still use that term? Do you think
I
it's still
do.
valid?
I do. I don't in talking to patients, right? So keratoconjunctivitis sicca, if you start going back and looking at the history, somebody decided at one point that they wanted to turn a more medical term. I think it was the 1970s when this came out. And it was actually more in line with trying to decide the difference between dry eye and like Sjogren's, which is an autoimmune issue, right? That leads to severe dry eye as part of its problem. So I still use it in coding and billing, right? So when I'm putting in my patients' diagnoses, I will still use keratoconjunctivitis sicca because I think that it, again, is, I don't know, I feel it carries a little more gravity. So when a patient looks at their chart or when people look at it, it's not just dry eye. I don't know why. I think it's a personal thing because it's not that I couldn't, for insurance purposes, also use the term dry eye, but I don't know. There's something in my own personal brain that I like it for coding, but I don't talk about it as that. Does that make sense?
Right. And it does to make sense to me. I also, in my head, the term keratoconjunctivitis sicca also describes to me the damage that may also be occurring on the surface, that it's not just the symptoms of dryness, irritation, but there's also like a deterioration of tissue somehow.
Yeah.
If that makes sense.
And that's what it is, right? Again, and that's why I said holds the gravity of a real problem because it's the perception and I don't think it's ever going to change that dry eye is just dry eye. As much as you and I really would love everybody to be like, no, it's a big issue. It just won't because that's just the perception with the term. But it is, when we talk about dry eye, we're not just saying feeling, right? We're talking about damage, desiccation to the front surface, the part that is so important for us to be able to see properly. And be able to function. So, yep.
Yeah. When patients see you in the eye clinic and you see damage or keratitis of something going on the surface, I imagine you usually have photos that maybe you can show a patient, but how do you describe what you see on the ocular surface? Depending, of course, every case is different, but how would you describe like what dry eye looks like from a doctor's point of view?
So I like to use the term, I like to talk about it like a dirty windshield, right? And thinking about the windshield having a bunch of speckles of dirt on there. And when I put the dye in, it's actually attaching to those little speckles of dirt, which are areas of missing tissue. And so when you see it, you definitely can appreciate that it really can affect the vision. So if I can, I'll show them pictures. Like I had a patient, were Sunday, so Friday. I had a patient who her husband was saying, okay, when you keep talking about this damaged cells and we were talking about this front surface like being worse, what do you mean? So I actually had him come in and sit in our slit lamp, right, which is essentially a high-powered microscope to be able to look at the front surface. And I said, hey, do you see all, look in there. I lined him up and I said, do you see all those little areas of bright green in the blue? And he goes, yeah. And I said, that's what I'm talking about. Those are all actually areas where she's missing tissue. And look at the other eye. And he's like, oh, that one's so much better. But pictures really do help. And I can't imagine, we're patients on the other end for other things. And I know for me, if someone can show me something, it really speaks volumes to being able to understand what's going on.
Right. And for anyone who's not sure what we mean by like seeing yellow of dye, so oftentimes one of the first things eye doctors do when we see dryness is we put what's called fluorescein sodium on the surface of the eye, right? Do you use both fluorescein sodium and you use lissamine green dye when you do assessments?
I do on the first appointment. And then if I'm not seeing something that's explaining the issue. So we've got two types of dyes. We actually have three, but we use two in dry eye for the most part. One is the fluorescein that Joey was just talking about. And that is that's what kind of glows green. I like to jokingly say you're glowing like a Christmas tree when someone's super dry, right? And that's essentially what it is. We put this blue light on, and it shows and enhances where the green is, and that tells us that green gets into little areas where there's damage in the skin on the front surface, and so that tells us where is the damage, what is it, how extensive is it, where on the eye is it, right? Is it inferior, which tells me maybe you're sleeping with your eyes open? Is it all over? And maybe you're allergic to some drop you're putting in your eye. And then the other stain that we use is lissamine green. And this is a really goopy, weird green color, but it actually stains different types of cells. So on the whites of the eye, which is the conjunctiva, it will stain on that tissue and the goblet cells in that area. And it can also, again, kind of lead us and point us in the right direction to figure out where your complaints are coming from or where the problem is.
So to kind of step back, I know it seems like in the eye care field, when I first was in school and then in residency, I was seeing dry eye all the time, but it almost seemed like normal at that point, like everybody had it. But I feel like our profession, the field of eye care, it's becoming like a bigger deal. And I can always question, is dry eye truly becoming more common? Are more people walking around actually getting and developing dry eye more now than they were several decades ago? Or do you think it's just that our profession is becoming way better at diagnosing it, understanding it, and just we have more treatments for it now, so we're just more aware that we can actually do something about it?
Right.
What are your thoughts?
It's a little chicken egg situation, right? So I think it's both. I honestly think it's both. I think that now that we are better able to identify and realize the downstream effects of dryness, right? That it can lead to damage to the front surface, to the nerves, which can lead to loss of vision. It can lead to needing corneal transplants, things like that. It's not just like this little baby issue. It's kind of can turn into a very big issue. And I think that our understanding of that has gotten better. So we are now looking to identify as well as our ability to identify. On the other end of things, we've got increasing use of our social media, of our device time, of our screens as we are all sitting here watching and listening to us, right? And that we have studies that show that our blink rate, normal blink rate is about 20 times per minute. When we're reading or doing something, when we're paying attention, we're down to about 10 times per minute. And then when we're on a device specifically, we're down to about 7 times per minute. And that leads to this lack of stabilization and homeostasis of that tear film and redistribution of the fluid there. So then we get this time where we've got exposure. That's going to lead to dryness. That leads to what we were just talking about, which is damage to those skin cells on the front surface, among other things. So I'm picking on screen time, but that's not the only thing. This is a really good question. We also are seeing an uptick in autoimmune issues. So the number of autoimmune issues that actually had names as of 15, 20 years ago was something in the 20s, 30s, right? Number of different known autoimmune issues. We're now up over 100. And there's still lots of my patients who have unspecified or undifferentiated autoimmune disorders. And with autoimmune disorders, that carries a lot of inflammation in the body, which then also causes inflammation in the eye and dysfunction of tear film production. So I can't say it's A or B. I think it's both. I think it's identification, and I think it's also we're just seeing there is just more of it.
Right. And I think because we're asking as a profession, we're attuned to it. So we may be asking more people to think about their eyes, because I think it's easy for us to get so kind of normalized of the discomfort, especially with things like device use. It's just like, oh, that just becomes part of your day now. You just don't realize that this irritation, the burning sensation, or your vision fluctuating isn't normal.
Yeah.
And so now it's coming to light a little bit more, where in the past it just sort of it became some sort of a normalized thing.
Yeah, and that's what what we and our patients do with a lot of symptoms is we normalize it. We say, "Oh, well, it just is, right? It's just dry," and without realizing that that's not normal. Some people actually don't have any of that, right?
So let's dive into more of like the causes, because I know a lot of my patients, they're always like, well, how did I get this? Like, how did this all of a sudden sort of thing? And I know we kind of danced around a little bit of like computer use, maybe a part of it, but there's many causes of dry eye. Like you kind of said that at the beginning with dry eye syndrome. It's like there's not just one thing. It's not just like, oh, I got an infection and all of a sudden now everybody has dry eye. It's like there's so many different things that kind of all pool into it. So could you kind of lead us off into how you think about it and some of the most major significant causes of the patients that you often see?
Yeah. So it's almost a little bit of everything, right? But that being said, yes, there are some things that are more causative or things that will lead to dry eye or worsening of dry eye. And there's different types of dry eye, right? We say dry eye, and I feel like it's almost like this umbrella, right? We need to also talk about meibomian glands and our eyelids. Our eyelids are so important. And there's so much that goes on with that we have to stop and think about that. That's a whole big component to it as well. So yes, computer usage, autoimmune, absolutely. Anything where there's inflammation in the body, I'm automatically buzzwords, right? That I'm thinking I need to be concerned. Our diabetic patients, diabetes leads to the longer that our patients have diabetes or we have diabetes, right? It leads to damage to nerves. When we talk about neuropathies in fingers and toes, I always ask my patients, how long have you had diabetes? And then how well controlled are you, right? And the third question is, are you having any tinglies in your fingers and toes? Because if they are, more than likely, they've also got some ocular surface damage, which may present as dry eye, or even to a point where the nerves that control a lot of that front surface aren't working as well either. So a lot of systemic issues, diseases, that really has a huge component with dry eye. And that's a big thing that I go through with my patients when they're coming in is what else is going on in your body? I need to know, not just now, but what has. Have you unfortunately had cancer, and have you gone through chemotherapy? Radiation I'm not concerned about because radiation is very specific to one area and it's targeting. Now, this is not 1920s. Radiation is very poignant and it's going to a very specific tissue. But with chemotherapy and some of the other drugs, they're treating the whole body. And what are they going after? Fast replicating cells. What is mucous membranes and our eyelids and our front surface of the eye? It's fast replicating cells. And there is a lot of side effects from chemotherapy that can be immediate and long-term with dry eye and worsening of it, as well as meibomian glands. Getting into the meibomian glands, right? So our eyelids have these glands in them, right? So they're meibomian glands. They have oil. The oil is super important. It provides nutrients to that front surface. So our cornea, right, which is where we were just talking about all that dye attaching to, right, where the dead damaged cells are. Well, that tissue has no blood vessels, right? And the way that it gets its nutrients is when you blink, you produce tears, right? And these tears have all sorts of different things to help that front surface function. And if the oil, which is a big part of that, doesn't come out of those glands properly, we start to lead to this imbalance in the tears, and that can lead downstream to worsening of dry eye. Now, multiple things can cause changes in those meibomian glands. Diet can be one, right? We eat our SAD diet, our standard American diet, right? High in processed foods and all of these chemicals that are in there. We are low and lacking in things like omega-3 and other nutrients because the more processed something is, the more nutrients get pulled out. And so that can lead to chronic inflammation in the body. That can lead to poor oil formation in those eyelids. So that's an issue, right? Then we can think about going back to the autoimmune, chronic inflammation in the body. We have patients who have rosacea, acne, all these things on the skin, which will affect those oil glands because acne and rosacea is an oil gland issue. Well, we have oil glands in the eyes. That can lead to problems there. We go on to medications that can cause damage to those oil glands, specifically Accutane. Unfortunately, while it's clearing up the rest of the face, it's clearing up those oil glands as well. And a lot of times they just disappear. Other ones we don't think about that I really want all of us to start thinking more about as doctors is eyelid position. and people having changes in skin from the face structure from multiple reasons. We talk about incomplete blink, which is really important, but thinking about what's the underlying cause of incomplete blink. So if we don't blink all the way where our eyelids meet, which is how that oil gets expressed, the oil's not going to come out. It's going to start to get stagnant, clogged. Those oil glands dry up and go away. So things that can lead to that incomplete blink can be related to muscle. It can be related to nerves. It can be related to skin. And some things that we don't think about is even just here, right? I just had my Botox done. So I grind my teeth, right? And so I've been getting I have dry eye. I've been having issues with nocturnal lagophthalmos where I sleep with my eyes partially open sometimes. And so I have really bad TMJ and I grind my teeth. So I just had Botox done in here to help keep it from pulling down, because we don't think about further down in the face. We think about just the eyelid, but it's pulling down. So that actually has been leading to me having some issues. But the list goes on and on about what we can look at. There's so many things. And I think while it's, I think, frustrating for some people, it's also really kind of cool, I know for me at least, to be like, there are so many things that you just have to think about when it comes into it. But that's why I want, the listeners and everybody to appreciate that it's so nuanced. It is not just dry eye at all.
And it's very just individualistic for like each person, because there's so many factors that kind of roll into it. I know another one for the eyelids that I'm always assessing for is floppy eyelid syndrome.
Yes. Yep.
That one came, again, when I was a student. I barely knew about it. And then in residency, I had a patient who had a severe case of it. So it was really obvious. But that kind of, again, as you do when you go to residency, your mentor tells you, okay, well, you're going to do a whole presentation, poster, you're going to like publish a paper on this as a case report. And so you dive into all the research about it. But for those of you who've never heard of that, that's where there's different connections to it. It's strongly associated with obstructive sleep apnea, but for some reason, proteins like elastin and certain types of collagen in their skin doesn't develop correctly, or they don't have as much elastin, and so their eyelids become very loose and malleable, and it's like when the eyelid closes, it doesn't close appositionally as close to the eye. Yep. And then when they're sleeping, it can flip inside out on itself.
Yes.
And then their inside of their eyelid could be rubbing against the pillow, or their eyes just, again, exposed to the open air, and then they have that dryness. So that's one that I know I'm looking for a little bit more often with my patients. And they'll be surprised sometimes, right? I'm sure you've had the same thing where you ask them, after you detect the floppy eyelid, you ask them, hey, are you on a CPAP machine, or have you ever been evaluated for sleep apnea?
Yeah. The patients do look at us like, why are you asking me about sleep apnea? And it's like, they're all connected. Yep.
Yeah.
I've sent plenty of patients out for that.
All right. Now, quick break. Now, if you've been following my content for any length of time, then you know I am very particular about what ingredients are used in artificial tears. And I talk a lot about preservatives, especially one called BAK, because chronic exposure to BAK has been known to cause not only irritation, but potentially cause worsening dry eye over time. And that's one of the big reasons why I'm excited to partner with TheraTears for this episode. They've been trusted in optometry and ophthalmology for years, and they've stayed committed to science-backed formulas that are gentle to the ocular surface. None of their drops contain BAK, and they also have preservative-free options that offer both immediate and long-lasting relief. And if you're somebody that struggles with eyelid issues or blepharitis, they do also have the Sterilid eyelid cleanser, which is something that I've used clinically, not only because it's effective and non-irritating, but it's also readily available, something that you can find both online and oftentimes even at local pharmacies. So if you were looking for a more thoughtful, science-backed approach to dry eye relief, then check out TheraTears.com to learn more. So I know we've covered a lot of different stuff. I do want to kind of wind back a little bit, because I know for a lot of people, when they hear dry eye, they think, oh, I'm just simply not making enough tears, right? And that's, I think, historically how our profession initially thought about it. we thought, oh, they're just not producing enough of like the liquid portion of the tears. But you spent a lot
Right.
of time talking about meibomian glands and the oils that are produced. But if we did just look at the tear production side of things, can you kind of break down? I know we mentioned Sjogren's syndrome as an
Yeah.
autoimmune condition
Yeah.
where people don't produce enough tears.
Yeah.
But can you talk just about a few things that maybe contribute to someone's just general tear production?
Yeah. So and I think even with that, stepping back, because nobody but us knows that when you talk about tears, it's not just tears, right? It's not just one thing. As I mentioned already, we've got that oil that's coming out that's part of the tears, right? But our tears have, well, arguably three, now apparently four layers. So the tear has, we'll go with three for simplicity, right? So there's different layers to the tear, and they're produced by different parts of the eye, and each has an important part. But what we look for is what's missing out of that so we can figure out maybe what is the issue, again, with all the other things that we look at. So we've got an oil layer, which is coming from those meibomian glands. We've got essentially an aqueous layer in the middle that's coming from our lacrimal gland. And then we have mucin, which helps it be sticky essentially to the eye. And that comes from goblet cells, which is in the whites of our eye. Okay. And so all three of these parts are super important. But if we see that somebody has low tear volume, like I put that dye in the eye, not only am I looking at where it's staining, but it goes into that tear, right? And so I can actually see how much tear is there and how much is being produced. And if I see that it's a very thin line and they have a low tear volume, I'm concerned that maybe that lacrimal gland is not producing what it needs to, or something's not releasing the aqueous, right? So then I would be, and this is important because it targets what treatment we might be going with. But Sjogren's is definitely someone who's going to have a low tear volume. People who may have dehydration, honestly, that's a big one, right? Especially here in Colorado. As much as you think we're all outdoorsy people drinking lots of water, we're just dehydrated people walking around. But those are the two big ones that come to mind as far as specific things that are causative of it. I think
I know a lot of medications though, too,
oh, yeah,
right?
thank you. Yeah, medication is a really big one too. Yeah, especially if we start talking about like our things for anxiety and for depression, as well as things that are for allergies. And even if it's an over-the-counter drug, it doesn't mean it's not going to have it's not going to have side effects, right? So when we take our Zyrtec, Claritin, anything that's got a decongestant in there, all of these can lead to a decrease in that lacrimal gland function and that kind of the aqueous part to it. And then also sleep meds, guys. So let's throw my husband under the bus. I love doing that every once in a while. My husband's a phenomenal guy, but he works night shift. He doesn't sleep very well, so he takes a diphenhydramine. So he takes a Tylenol PM or whatever PM, right, to help him sleep. But if a doctor asked him if he takes any medication, he'd say no, but he takes it every night. So don't forget to tell your doctors that even if it's not a prescription medication, anything that you're taking over counter, they have side effects that could be adding to some of your symptoms.
Yeah, for sure.
Yeah.
I'm always looking at the medication list
Oh,
and
yes.
trying to make sure I understand what they're taking. I think high blood pressure medications also,
Yeah.
some older forms of those that I'm just like, oh, that's going to dry your whole body out.
Yeah.
Um,
It's hard to list all of it because there's just so many of these that do, but there's usually like, we'll look through it and be like, yeah, you, pain medication, our Ambien, all of these things. What is your thought on GLPs? Like, not in such as that I can't tell if they are causing more dryness or because people are on GLP-1s, they're just taking in less food. And my patients have told me they just don't feel like drinking water. So I just don't know if it's a physical dehydration or if there's anything. And I just don't know that we know yet.
Yeah, thanks for asking that. I know there's been quite a bit of attention on GLP-1s.
Yeah, for some other reasons too.
For the last few years, even more so in the eye care field, which is something I planned on doing a new video on. I did one when that information about GLP-1s had first come out.
Yeah.
But as far as dry eye concern, I don't really have an answer for that one. My my sort of reasoning would probably fall similar to yours, that it's somehow people just maybe aren't drinking as much, because we also do get a lot of our fluids from eating
Food.
food,
Yeah.
right? Especially if you're someone who doesn't drink a whole lot, you may be getting it more from eating fruit or from whatever you're eating throughout the day.
Yeah.
And so that might be the connection there.
Okay.
I know another topic I'm really interested in, and perhaps we'll have a hormone specialist come on and speak more about, is perhaps the relationship of like female hormones and changes as we get older and their effect on dry
Yeah.
eye,
Yeah.
because
And
that
that's a big part too. And that's, so age has gone by, we would say that our dry eye patients are women over 50, right? And it's just women over 50. It's just assumed automatic. And it is because of hormones. And it's not incorrect that yes, they are probably more likely to have dry eye or worse symptoms and signs, but it is not only. And then you got to remember there's hormone therapies, right? For women who are post menopause. And so what does that play into it? And so hormones, I'm always looking at it, but it's such anytime you have an imbalance, if it's too much, too little, or it's a change, right? And around the time of change, so patients who are going through HRT, who are transitioning, who are just new on hormones, they will tend to have a worsening of dry eye, especially if there's an increase in testosterone or in progesterone is what I've seen. But it's not, but a lot of times once it stabilizes out, it kind of swings back. So
yeah.
it's so nuanced on that one. That is definitely, that's a, yes, get a specialist.
So, being kind of on that same note, but what are your thoughts on thyroid and thyroid's relationship with dry eye disease?
Yep, there's definitely an increased risk for dry eye with thyroid, and that's not just someone who's had, especially if it's uncontrolled, because anytime we're talking about hormones in the body, that's really anytime we have an imbalance, we'll see worsening. There's different types of thyroid issues, right? When we start talking about like Hashimoto's, so Hashimoto's is also an autoimmune, which that's going to lead more often tends to be correlated also with rheumatoid or Sjogren's. Not always, but they do tend to try to hang out in a pack for some reason. That's a very specific, but then you also have people who have thyroid eye disease, right? Where they've started to get to the point where the eyes are starting to bulge and you actually are getting physical changes to how the eye is sitting and how the eyelids are closing. And then you have just our general thyroid issues where we've got a little bit of increase T3, T4, or some of the levels are off. And then those people also have dry eye. So yes, I would agree if you have a thyroid issue and it's, especially if it's uncontrolled, that we're more likely to have, symptoms of dry eye at that point.
Right. So that's, I think, I mean, I've read different things in the research that, for truly not having high levels of tear film is maybe only 15 to 20% of cases.
Yeah.
Would you say that's kind of about the ballpark for those? Like people who truly just like their oils are fine, but they're just not producing any tears. You just say that's kind of that ballpark?
Yeah, it's about 15. I think the DEWS report that just came out said 60% are MGD or meibomian gland dysfunction and aqueous, based on the research, and it depends on what you look at, right? And then you've got essentially 20/20 or 15/15, give or take, of those that are purely meibomian gland dysfunction or purely aqueous deficient.
So let's dive back into the meibomian gland kind of dysfunction, because that is a large portion of people have some component of something going on with these oil glands. And I've talked about it in a few videos on the YouTube channel, but do you mind kind of, again, you've already kind of teed us up of what's going on, right? The oils, they help coat the tear film, they help prevent it from evaporating.
Mm-hmm.
They also basically stabilize the tears.
Yeah. Yeah.
Can you kind of go more into like what are some of the causes for meibomian gland dysfunction?
Yeah. So there's lots. I mean, it kind of goes back to that, are the glands being expressed properly? So if for some reason we talked about eyelids, right? If the eyelids aren't getting a proper seal or pressure, and the muscles around the eye aren't getting the correct compression to push out that oil, that can lead to the oil not coming out to get out to the tear film to do its job. And eventually it kind of starts to get congealed in there, and then the body, I essentially say the body says it doesn't need it if it's not coming out, and it lets it die. And then the glands atrophy and go away. We don't like that. We don't want that. We need those. Other things, bacteria, right? Bacteria is a big one. And specifically, we can talk about rosacea and acne. If you've got that going on, there's probably some level of issues with the meibomian glands because they're also an oil gland. But even just, people don't think about it, but why do we brush our teeth and wash our face? It's to control bacteria, right? And we need to be doing the same thing. This is my soapbox. And we need to be doing the same thing for the eyelids because we need to control the bacteria so it doesn't create a problem, even if you don't think you're having one. So, daily lid hygiene helps to control the bacteria, control inflammation. Also, it's good around, getting things off from the day. If you've got allergies, if you're putting allergy drops in the eye, but you're not washing the face to get the allergens off, is that helping? And so controlling bacteria is important so it doesn't get into those glands. That can cause a change in the oil, and that cause it again to kind of become thickened. And then the body says, I don't need you, and they go away. And then we've got this other friend, and more people are talking about this. I love that my patients are coming in knowing what this is, so I'm not having to just shock them, but Demodex blepharitis, right? So kind of just like we've got bacteria, part of our natural flora and fauna is we have these little mites. I know it sounds awful. Don't worry, we all have them, but they are part of our natural flora and fauna. They live in our oil glands and hair follicles, very specifically on our face. We see the most concentration there. And when they get overgrown, they start to cause changes in the oil glands from a couple different mechanisms. They're in there, unfortunately, living their best little lives. Some of us have seen those commercials on the TV of mites having a party. Yes, they're in the glands. They're, living, dying. Everything's happening in there. Hope nobody's eating while they're listening to this. Sorry. So that leads to those oil glands, again, congealing. The oil's not coming out. The glands die. We don't love these. These are not good things. So those are probably the big three things. There's plenty of others. Some medications, I already mentioned chemotherapy, are Accutane, some retinol we have to be very careful about. Things that are like lash enhancing serums, right? So I love long lashes. They're gorgeous, right? But when we use lash enhancing serums, some of them have something called a prostaglandin in there, or a prostaglandin analog. And this is a pro-inflammatory component. Yes, we use some of this for glaucoma that's in a drop, right? Something to help lower the pressure, but these are some of the side effects we know from those as well, is it actually will cause atrophy and damage to those glands, as well as discoloration of the skin around the area. So we have to be very careful, right? Lash extensions, while I do not love them, they don't have a prostaglandin, but they do have glue, right? And that glue is not made to be near the eye, but that's where we're using it. It can also, having those on there, lead to, we still need to clean even if we have lash extensions, because that can lead to bacteria overgrowth and Demodex and things like that. So am I missing anything? Can you think of any other?
Those certainly are the biggest things, except for maybe just like preservatives and eye drops. That's another thing that's kind of been a big focus in the last few years in the profession.
Yeah, absolutely.
Because of some research that came out showing that one of the most common preservatives, right, BAK or benzalkonium chloride, has a strong irritant to the surface of the eye and may damage these meibomian glands themselves.
And I think we're more familiar, that's a really good point, because I think we're more familiar, especially as doctors, that this preservative that's in there is irritating to the front surface. And we don't think about the fact that it also is irritating to the conjunctiva, or that, white part of the eye, as well as those meibomian glands. And that's a really good point. So most of us, as doctors, will tell our patients to make sure that you get a preservative-free drop, as far as if you're going to be using it more than once a day, in my personal opinion.
Yeah. I personally try to just, I'd like to go preservative-free no matter what, if possible.
Yes.
I'm hypersensitive to BAK. I found that out in optometry school. One of my classmates put a specialty scleral lens on my eye, but used eye wash instead of sterile saline. And so
Oh,
I had, that was when I first found out, oh, I don't just have a normal reaction. I have like a hyper reaction to this.
oh
Uh,
no.
so I personally like to go that way.
Yeah.
The I think the one other area that I would love to kind of just have kind of our rounding points on kind of goes back to the very beginning, because we've talked about, okay, the aqueous production, right? You
Mhm.
produce just the watery component of the tear film, which again is not just water; it's electrolytes, it's proteins, it's
Yep.
antibodies,
Yep.
all these healing
Yep.
properties.
That's why an
But
artificial
then,
tear is an artificial tear. There's actually 1,500 different components to your tear. It's a very
right,
complex little drop.
so we have the watery component of the tears. Then we have this oil component, this from the meibomian glands, which
Mhm.
is doing a lot of good to stabilize the tear film, to coat the surface of the eye, prevent it from evaporating. But then, if there's a breakdown and you start to have truly dry eye syndrome, and the tears are evaporating, and you're having this damage to the surface, then there begins this other process. This kind of inflammation starts
Yeah.
boiling up, right?
Yeah.
Can you kind of break down what's going on with the inflammation and the inflammatory cascade that occurs?
Yes, absolutely. With the inflammation, so anytime you have damage to the tissue in your body starts to release T cell mediators and all of these different components to essentially address what's going on. Now, the problem with that is that it actually starts to cause more damage, and it disrupts the production of those tears and the proper kind of balance of those tears even further, which is not ideal, right? We don't want it to continue down this kind of path. So, I mean, I don't know how much you want me to get into all of the T cells and the and in our apoptosis and all the fun things there on
That
a
might be too
Sunday
much right
morning, but
now.
yeah, right. But that's the big thing to know about it is inflammation is not good. I think all of us can agree and we understand inflammation, right? When we hit something, right? We have an achy joint and it's swollen and our body is kind of essentially almost trying to help itself but making it worse by sending all of these mediators to that area. And we kind of have to, when we talk about treatment, we're really trying to one, address the underlying cause that may be leading to the inflammation, but also breaking down that cycle so that it doesn't continue.
Yeah. And I know I always have to kind of think about those major steps because of kind of how we treat dry eye. What is doctors what we have in our toolbox to help manage it, right? We certainly have things like eye drops to help, in the moment kind of give this protection to the tear film, supplement, make sure it has more liquid to actually protect it. But then we also need to do something to get those oils producing better. We want to, those are usually through procedures that we have in the clinic to get the trapped oils out and potentially even put like an artificial type of oil on the surface to help stabilize things. But then we have a lot of our treatments historically and currently are to somehow kind of manage or dampen down the inflammatory cascade.
Absolutely. Which in some patients, it's not just inflammation from damage, right? We go back to our autoimmune, our Sjogren's, our Hashimoto's, our uh, my patients with Crohn's. I mean, it's anything. We get into the whole gut biome thing. All of those things where it's chronic long-term inflammation, they're going to need to be on something that not only addressing the underlying systemic, but controlling the inflammation long-term on the front surface of the eye, because they're just unfortunately, we aren't going to get rid of an autoimmune disorder, even if it's under control. It's still there kind of causing some trouble underlying.
Now, there's so many different things. If we really wanted to go into every single treatment about dry eye, we'd be here for like 3-4 hours.
Right.
Uh, but I think from just like knowing lifestyle things, that's always a big topic. I'm trying to help people understand. There's a lot you can do just day to day to try and diminish not only symptoms, but to reduce how frequently your symptoms may flare up if you're battling dry eye. But do you have any just lifestyle things you typically talk to your patients about? I know it's tough because again, everybody has a very
Yeah.
individualistic condition,
Yeah,
but is
absolutely.
there general things that you think people should know about?
There are. I think that, and there are three things that I talk about with all of my patients, because I think that everybody should have this baseline. And again, it goes back to that brushing the teeth and flossing that we should be doing for the eyes that we never talk about. And maybe this will change with your and eye health over the next 10 years, right? But things to help with those meibomian glands, I think, is one thing that is probably the easiest. Going back to lid hygiene, right? With a daily lid cleaning. It doesn't have to be twice a day, just once a day, something to kind of clean at the end of the day to get it off. Be careful about what we're using, because there are, unfortunately, it's over the counter, and FDA doesn't really watch a lot of the things that are in there. So going back to the preservative issue that you were talking about, there's a lot of bad actors and a lot of bad preservatives that are out there that can be in some of these products. So just be careful in looking at what you're getting. Something that's preservative free is ideal. There are wipes, there's foams. I have a number that I absolutely love. Am I allowed to say anything on here? I don't know. I'm not plugging, but
what we'll do
I
is
love
we'll put
okra based. I love an okra based foam. It's like my favorites. There's a couple others that are out there, but
right. There's some ingredients that we know of, whether it be tea tree oil, whether it be okra, whether it be manuka honey. There's a couple different ones, and we'll put a list of not only my favorite but your favorites in the show notes below. So if people are looking for, hey, what actually is preservative free, or what is
that's
something
the
that's
hard
often
part. If you go
recommended,
on
we'll put our
Amazon,
favorites.
if we go on the Smamazon, whatever. And we go to find things, it's going to tell me to buy 12 other things that are not what I want my patients using. And that's really confusing for everybody to say, okay, well, great, but what do I use? And where do I find it? Because I'm saying not everything's good, but you need to know what to use. So there's lots of good products that are out there, but I would say it is just be careful. There's also been a number of things that have had FDA recalls. Your doctor should be aware of those. If not, I know Dr. Allen here will make sure everybody knows where you can watch those things. But it does not mean when we say tea tree oil, okra, and manuka honey, go get food grade and then use it, right? And some of my patients jokingly say, oh, so you just want me to go get okra and rub it on my eyelid? I'm like, no, I don't want you to do that. But there is a difference when we talk about things that we get in form, dose, and ratio of how they're made, right? Manuka honey is being used in lots of different parts of medicine for healing properties for like diabetic ulcers and feet, but it's medical grade. It's not the one that I go to the store and pick up and I'm using, right? Same thing with tea tree oil. We don't want to go get one that I'm going to potentially put in an incense burner because it's got a beautiful smell and put that on my eyes. So we have to be very careful about that. Yeah.
What about, I was going to ask about hypochlorous acid. Is that one that you've used?
Yes.
Do you love that?
Yeah, I do like hypochlorous. Again, you have to be careful about which one. I got to go down this beautiful rabbit hole of how is it made and what the differences is in between them. And some are better than others. If it smells like chlorine or pool water, probably don't want to use it. It means that it's turned. But yeah, so I do love it. The idea with that is it's actually something our body naturally produces to attack the bacteria, right? The ones that are not supposed to be there, and it helps to lyse them. So it is used in wound cleaning. There are some that are FDA approved for 510 clearance for the face to use on the eyelids as well. And again, it's kind of one of my personal, once I've cleaned, I do a couple spritzes, I let it air dry, and then I'm putting on any moisturizer or any kind of creams that I'm using.
Yeah, I love that.
Yeah. So that's kind of part of the cleaning. There's a number of different things that we can use, but we got something that probably works for everyone. The next thing is warm compresses. And some people may be going, I don't want to do that. Or doctors may be going, it doesn't do anything. Well, okay. I will tell you, yes, and in patients that need further treatments, no. But just because I go have my teeth clean doesn't mean I'm not going to go home and continue to clean them, right? So warm compresses, we have to do it appropriately. It needs to get up to 106 degrees before it's considered therapeutic, where it actually melts the oil that's in the glands. And that's what we're trying to do, is we're just trying to melt
that's 106
the oil
Fahrenheit, I imagine.
Yeah, right? Yeah. So best you can. And I don't tell my patients to do it every day. I'm like, if you get 3 days a week, I'm going to be ecstatic because I don't remember to do it every day. So I do like that in there. And then
It feels
the
good too. It's comforting. If anybody's listening or watching and they haven't tried doing a warm compress for the eyelids,
yeah,
it's like a spa-like treatment,
it
I
is.
like to describe it,
I like the
'cause it
air
feels good.
activated ones for when I'm on a plane. I put
Mhm.
one of the air activated ones on and I just go to sleep. So it's always nice.
Yeah, I think, the only time I think for some patients who have heat sensitivities, like,
Yeah.
right, with, if they have
Rosacea,
rosacea.
if it makes it worse, don't do it. There are some people where it's like, yeah, nope, this is not my thing, and that's okay.
Mhm.
Yep. Last thing that I do try to talk about is like things that people can do at home, is nutraceuticals, right? We can talk about omega-3s, omega-6s, as well as there's some antioxidants looking at lutein, zeaxanthin, vitamin D, curcuminoids. There's a number of things. I think ashwagandha has also been shown to be very helpful. Uh,
I haven't heard about that ashwagandha. I'll have to dig into the research, and maybe that'll be a new
The other
YouTube
ones are
video. I'll
definitely
look
bigger.
into that.
There's a little bit of research on the ashwagandha. I kind of question whether or not what's going on with that. But the idea is with each one of them, we're just trying to put things in our body that we may not be getting at a high level to try to promote better oil production. And, each one of us has our own favorites, which direction we go. We get a lot of sixes in our diets. And I know some people will talk about sixes being pro-inflammatory. There is GLA, which is anti-inflammatory 6. So it's yes and no, sure. But what we're talking about when we say the pro-inflammatory 6s is more of the stuff that's in the processed foods, things that are part of like the oil fatty. You've done the deep dive on this, I know. So it's, but there's good and there's bad actors again, because not all things are produced equally. We just have to be thoughtful in what we're getting, and making sure we're getting things that our body are going to absorb and that agrees with our body.
Yeah, and I'm glad that you mentioned all of that, because those are all things that I typically follow, not only for myself but talk to my
Yeah.
patients about. The nutraceuticals or supplements and vitamins. That's a fascinating area. Just
Yeah.
diet and how
It's overwhelming,
how
but it's fascinating.
it is, but what we eat, what we put on our bodies, how it affects our GI, and then the effect on inflammation in our immune system throughout your entire
Yeah.
body is
Yeah.
really interesting, and I think plays an integral role in dry eye and certainly other eye conditions too. So perhaps we can do another episode down the road, and we'll talk more about that.
Yeah. It'd be fun.
But Dr. Koetting, thank you so much for being here, Cecelia. You're amazing. Really appreciate your time. And from here, we'll kind of save more questions for dry eye for the next episode.
Sounds good. Thank you so much for having me.
Thank you.
You've been listening to the Dr. Eye Health Podcast with Dr. Joseph Allen. For more resources, trusted information, and helpful tools, visit dreyehealth.com. Thanks for joining the community that's focused on healthier eyes and a healthier life. Until next time, stay informed and keep your vision sharp.